than the Delta. So in the past, we used to call them by the country of origins, but this cause stigma, so that's why they changed it to the name. And then epidemiology, so children are less commonly affected than adults. Okay, about 13% of global COVID-19 positive happen in children. And then 1.4 to 3.2% of total COVID-19 hospitalization are children, and about 0.03% of death rate. Okay, and in US, only less than 2% of children hospitalized. The rest are actually managed at home. And then US data showed that there's increased proportion of children. Okay, at the earlier part of the pandemic, there's only about 3%. Now up to 19%. For example, like in May and June, there's time where the pediatrics numbers up to 21% of the total case. And why? Why is it so? So there's a lot of theories behind it. Some people claim that the adult vaccination was actually one of the reasons, because vaccination reduced the rate of infection and also symptomatic infection. So basically reduce the uptake, the rate of diagnosis in adults. So more children, proportionately more children being diagnosed. And then the presence of new variants, which is more transmittable. In the early phase of the pandemic, we don't see much school outbreak, but recently, especially in the early this year, we see a lot of a lot of outbreak in school. So that's where we've got numbers of children increase. And then, however, severity remain despite the emergence of multiple new variants. The severity remains. So again, up to now, the hospitalization rate is remain about 1 to 2%. The death rate also remain very low, about 0.01 to 0.03% of the total death rate. And mortality still very low. However, remember, COVID now is actually the top 10. It's always at the number 6 or 5 to 6 causes of death in children. Okay, so even though it's low, but it's significantly contribute to death in children. How about Malaysian data? So we've got total, this is up to June lah. I only got data up to 4th June. So we've got total case of 82,000 with 15 deaths. Okay, less than 5 years contribute to the highest, which is 0.03% of all the 0.5 all of the less than 5 years old cases, and then followed by the teenagers 13 to 17 years old. Okay, 60% of the death got comorbidities. So this is similar to the world data. 25% BID. So remember, we've got cases, especially in Sabah, we've got few cases of BID. Children came with BID and turned out to be positive COVID. And 25% of them are actually non-citizen. But the numbers is low. It's only 15. I think up to now, there's only 16. If I'm mistaken, the latest, we've got one new death. I think about there, 15 to 16. But again, the number is quite worrying because in 2020, half of the numbers are actually less than half of the numbers. There's only 3 deaths in 2020, but the whole up to the half of the 2021, we've got already 12 deaths now. So the numbers of deaths is increasing, but most likely contributed by the increasing number of incident in pediatric. And then how about statistic in Kuantan? This data I've got from our PKD, District Health Office of Kuantan, but only up to 17 June. So total of 4,100 cases among pediatrics. Youngest is actually 24 days old, and the oldest is actually 90 years old. So children comprise of 20.7% of all of the cases. And then 57% were boys. There's no mortality recorded in Pahang, which is good. But compared to national data, there's more school children because there's a lot of school outbreak in Kuantan. Okay, I think that's one of the reasons why the government is pushing for vaccination of teachers, because we are aiming that once there's herd immunity among the teachers, hopefully we can open up the school much earlier. Okay, and then how children get infected? So in general, there's still inconclusive evidence on where the source is, but we know mainly from adults, because actually in children, they've got lower odds of getting infected after close contact with a positive patient. For example, if you got about half, so the risk for getting infected in children is half lower than the adult. And then attendance to school is not a risk factor based from epidemiological data. However, the outbreak are mainly due to inconsistent mask use and also the SOP, which is quite difficult, especially in young children, to prevent them from physical contact and also close contact. Vertical transmission is very rare. It's only 5.8% incidence, but the dilemma is to diagnose, because PCR is only about at most 70% sensitivity in babies, in neonates, in newborn. So there's chances that newborn who was born from mother with COVID positive are still positive. About 30% of them are still positive despite PCR negative. And then children of all ages can transmit COVID-19 to others. Remember, children of all ages can transmit COVID-19 to others. But of course, in very small infant, the rate is much lower, except for those who underwent aerosol generating procedures. For example, babies admitted to NICU, had suction done, or those received nebulization. So these are the risk factors for transmission of disease from children to others. Age are not correlated with viral load. So the smaller infant, they can still have much higher load of virus compared to adults or even or young or older children. ACE2 expression also did not correlate with viral load. We know in children, the ACE2 expression on the lung surface is much less compared to adult, but the viral load can still be very high. Okay. And again, viral load not directly correlates with the risk of infecting others, because there's a lot of other factors involved. Then clinical manifestation. So how do children presented? So in general, majority were mild. Okay, about 45% were asymptomatic. Anosmia and agusia is not common in pediatric. Okay, fever, poor feeding, very non-specific symptoms common in babies, in neonates, but 17% of them were actually asymptomatic. Okay, risk factors. The main risk factors are actually comorbids and also age less than 1 year old. Okay, these are actually risk factors for severe illness and also death. Okay, comorbids such as type 1 DM, obesity, chronic lung pathologies, genetic anomaly, especially trisomy 21. Okay, and also prematurity and its complication are the main comorbids that contribute to severity of COVID-19. Actually, presence of one comorbidity actually double the risk of severe disease and 3 times increase the risk of death. So we have to protect our children with comorbidities especially. Okay, conflicting outcome in cancer and post-transplant, looking at meta-analysis, looking at studies and case reports of cancer and post-transplant, they are conflicting evidence. Okay, some say it's increasing risk, but overall there's no increased risk in the rate of severe disease, also death among those with cancer and post-transplant, immunocompromised. And then post-acute COVID effect was self-limited. Okay, it's only mild most of the time, up to 8 weeks to 2 to 8 weeks of cough and lethargy, usually complained by the children. Compared to adults, okay, post-acute COVID in adults are quite prolonged and quite severe, but in children it's only mild. Any questions? And why mild representation? Okay, people wonder why children are like less affected by COVID. Yeah. So basically, these are few of the hypotheses. Okay, number one, has lower ACE2 receptor expression on the lung. Okay, we know that the lung of children actually keep developing up to 6 years old until they reach the maturity of adults, and so they've got less ACE2 receptor that can be the entry point for viruses. And then there's a good ciliary movement of respiratory epithelium. Like adult, we exposed to more damaging like gases, and also smoking, and if you're smoking, passive or inactive smoker. So our ciliary is not, ciliary function is not as effective as children. So children can actually get rid of the viruses particles better. And then effect of childhood vaccination. So studies found that effect of childhood vaccination, such as BCG, can actually activate and also increase the innate immunity. So it become like a protection from other like common illnesses, common virus in pediatrics. And also there are some cross immunity from previous cold coronavirus. So basic coronavirus is a very common virus, one of the commonest virus that cause upper respiratory tract infection in children. In fact, most of the people have been infected. If we check the antibody level, actually most people are already seropositive for common coronavirus infection. And then there's higher amount of soluble ACE2 receptor. So basically there's two types of receptor, ACE2 receptor. One is those expressed at the surface of the lung, and there are also ACE2 receptor soluble in the serum or in the blood. So this ACE2 receptor are quite prominent in pediatrics compared to adults, and it acts like a neutralizing antibody where it binds to the virus, so prevent the virus from actually manifest the symptoms. And then use of ACE inhibitor in adult have been shown to increase expression of ACE2 receptor. So that's why people with ACE inhibitor, they've got theoretically they've got higher risk of more severe infection because of the increased expression of ACE2 receptor. And then in pediatrics, especially younger children, they've got low production of cytokines, and we know the main pathology that leads to mortality and severe presentation in patients with COVID is actually because of cytokine storms. So that might explain why pediatric have milder presentation. And then one important pathology, one important pathology that occur in pediatric is the multisystem inflammatory syndrome in children. The same goes, adults also can get similar symptoms, but they call it MISA. But in pediatric, it calls MISC or Kawasaki-like illnesses. So the case definition is usually the age has to be less than 21 with fever and sign of inflammation. So this include like increased ferritin, increased interleukin-6 or CRP, and then 2 or more organs involvement. Can be anything, can be skin, like rashes, vasculitic rashes. This can be liver involvement, or myocarditis, can be anything, more than 2 organs. Or even brain can also affect it, encephalopathy, things like that. And no alternative diagnosis. So if you look at the diagnosis, it's quite similar to Kawasaki. It's quite similar to Kawasaki. And the presentation is also similar. And there must be evidence of COVID-19 infection in the last 4 weeks. So this can be through PCR or antibody level, IgG or IgM level. It's very rare in less than 1 year old, okay, because we know less than 1 year old, their immune system is not that developed. So they are less likely to produce inflammatory response, but most common between 5 to 9 years old. Pathophysiology is dysregulated humoral responses with high IgM and IgG level. Okay, this is non-specific IgG and IgM level that cross infection, that can be cross infect to any common viruses. And then treatment is only supportive and anti-inflammation, so like IVIG and also methylpred. Okay, by May 2021, there's 3,700 cases reported in US with 35 deaths. Okay, at least half admitted to ICU. So there's a significant comorbidity and also mortality can be contributed by the MISC. So management, I'm going to touch a bit about the vaccination. So now there's not many vaccines proven effective in children. Pfizer licensed under the EUA emergency under EUA FDA for 12 to 15 years old. But we have to weigh, okay, why vaccine is difficult decision for vaccination is difficult in pediatric compared to adult, because vaccination has its own side effect. Evidence shown that vaccination can actually lead to myocarditis. Some of the complication is myocarditis and also MIS-C-like illness. But this is mainly in teenagers lah. It's affect mostly children between 16 to 24 years old. And also the cases so far, reported cases of myocarditis secondary to COVID-19 vaccine is 16.1 cases per million. So every million children being vaccinated, we've seen about 16 cases. It's not that big, but it's very significant because myocarditis has very high risk of mortality. And then we have to balance between, shall we vaccinate children when the disease are mainly not severe and they don't have much mortality numbers compared to adult. So we have to balance this. So that's why FDA approval is difficult to get for children. In terms of treatment, is mainly supportive. Up till now, only remdesivir and also dexamethasone are licensed in pediatric, but center we just supportive. Okay. For MIS-C, definitely immunomodulatory like IVIG and corticosteroids are the mainstream treatment. Isolation, according to CDC, those asymptomatic children should be kept isolated for 10 days. For severely ill, 10 to 20 days. For severe immunocompromised, until PCR negative. So, studies, systematic reviews shown that in severe immunocompromised children, PCR can actually remain positive up to 4-5 weeks. There are cases up to more than 2 months of PCR positive in severe immunocompromised. And this can be positive in stool, in urine. So stool clearance, for example, in one of the case report of a child with leukemia, the PCR remained positive in the stool even after 4 weeks post-infection. So this also become dilemma for those attending nurseries, because the virus can actually be shed in the stool and also in the urine, and can remain prolonged shedding. Next is the impact. Okay, in general, impact can be both, because the impact of COVID can be direct or indirect. For example, direct impact from the infection itself, indirectly through the MCOs and also isolations, and also psychological impact. So, for example, MCOs can lead to increased food, snacks consumption, reduced physical activities, increased screen time among children. Okay, and of course they don't get enough quality education during the MCOs. So this to some degree has effect to them as well. So we are expecting to see more metabolic syndrome or like nutritional related illnesses or comorbids in near future. And then nearly 14 million children did not receive any vaccines in 2019. So this is data from UNICEF. So we're expecting more outbreaks of vaccine preventable disease, okay, VPD. And then vaccines uptake reduced by 40 to 75% in different countries. This is not only occur in developing countries, but also developed countries, okay, because developed countries also affected severely from COVID-19. And then, for example, like MMR and HPV vaccine last year reduced by 51% and 78% each. And also there's 4-fold increase in incident of polio in Afghanistan and Pakistan. We know that currently there's most countries in the world already polio free, right? Except for Afghanistan, Pakistan. But now because of the uptake is already low in Afghanistan and Pakistan, but last year there 4-fold increase in incidents, which means the uptake is much lower. Okay, so we are expecting to see children coming in with diphtheria or measles, complicated measles, and so on. And then almost 60% reduction in attendance of outpatient follow-up. Okay, this affect those with chronic disease, mainly because of fear of catching the illnesses, catching the virus. and also because the policy, hospital policy, for example, like our policy, we postpone elective follow-ups or elective procedures of patients from PKPD or from red zones. So additionally, there's additional 200,000 stillbirths, okay, last year. This is mainly poor to antenatal checkup, mainly in developing countries, but it is also occur here in this country. Looking at the data of pediatric mortality and pediatric cases in Malaysia, about, for example, like mortality, 25% are actually foreign. Okay, these are mainly the Rohingyas, the Bangladeshis, and the foreign people who actually came to our countries. So these people, they don't have good antenatal checkup, okay, at the beginnings, and then now with the pandemic, there are less antenatal checkup, and they actually contribute to the data. So they contribute to our mortality data. So we've got additional 200,000 stillbirth. Psychological and the effect to the mental, there's increased risk of violence and abuse, mainly due to multiple factors. Okay, it's both factors from both sides. For example, like job loss, economic uncertainty, and social isolation, causing distress to the carer, to the caregiver, and also weak child protection service. You know, child protection service are quite slow at the moment because of the restriction. So because of the pandemic, so children are less protected, okay, by the external environment, and the internal environment is also violence during this VUCA period, and volatile, uncertain period. So there's increased risk of violence, definitely. And then the impact on caregivers is also significant. For example, like anxiety occurs in a study involving like 31,000 carers. This is a worldwide studies. I think Malaysia also take part in the studies. They found 52%, more than 50% of caregivers are actually suffered from anxiety, and about 25 to 27% develop depression. And this is something real. Okay, this is something real. I'm not sure about others, but me myself, I think I'm crazy enough now handling the children for the PDPR, attending, came to hospital. I brought my children to hospital for the PDPR. And because now parents have to play the role of parents, you have to play the role of teachers, physician for your own children. So, and of course, being at home, for those who work from home, are very, actually working from home actually increase more job for the housewives. And also for those working at home, because now you are seeing the effect of children being at home. Okay, before this, children was left in the school for most of the time in the day, but now they are staying at home. So more chorus have to be done, more cleaning up. So a lot of carers are actually affected. Okay, and then in children, data shows that 29% of children involved in the study develop depression, anxiety. There are more developed sleeping disorder, PTSD. In overall effect, is about 79% cumulative effect. So we know psychologically children affected. These are actually especially children that they themselves affected by COVID, or their parents are affected by COVID. They've been isolated, or they've been being quarantined at home. So due to MCOs and so on. Socioeconomically, so schools for more than 168 million children closed for almost entire 2020. So in last year, 168 children did not attend school for almost an entire year. For example, my elder daughter last year only attended school, I think, from September to November, and also from January to March. So from March until September, we homeschool our children. Anyway, and then 1/3 of the school children are unable to access remote learning. So remember, this is significant. This is very significant findings, because remote learning is a trend now because of the COVID. So if 1/3 miss the school because of the access, so definitely there'll be they lost the opportunity of school of learning. And then UNICEF projected that in the next 1 year, an additional 140 million will live below the poverty line. This is based on the current data. Okay. So I think that's all. Conclusion. So in general, COVID-19 in children are mild. Okay. Severity and mortality are higher in children with comorbidities. Remember, even though it's low, but the morbidity and mortality is quite high. Okay, it's relatively high in children with comorbidity. This include obesity. Okay, obesity contributes to a lot of comorbidity, but study found mainly in elder children, those like the teenagers more than 12 years old, affected by obesity more than the younger children. And then the new SARS-CoV-2 virus variants actually a threat lah. We're not sure how it will affect the children in future, especially especially with adult vaccination. So it's also a threat lah to children. And then we've got vaccination dilemma. Of course, so we don't expect to see vaccination in children soon. Okay, it will take some time, vaccination in children. So the main things that we can do now is actually following the SOPs and also social distancing. And finally, COVID-19 directly and indirectly impact children on every aspect. So it's not only the health, okay, physical health, mental health, psychosocial effect, and also economic effect on children just as much as adults. Okay, of course, we know most people think COVID-19 is a disease of adults because it's affecting adults by numbers higher than the children, but actually it does affect children a lot. Okay, so these are my references. So I would like to acknowledge two of my MOs, okay, Dr. Nadira Ismail and also Dr. Khalid Amrin, for their effort in helping me preparing the slides. I think that's all. Any questions?
There's one question, Doctor, from Husna. The question is, how would you different if it's an active infection or not in an immunocompromised patient since the PCR can be positive up to 2 months?
Okay, that's a challenge. Okay, that's a challenge. Because first PCR just tell you that the virus is there. Okay, it can be that virus or it can be live virus. So what we do, if you want to confirm, what you will do is you have to take the serology such as the immunoglobulin level, IgG, IgM. But again, IgM can remain. A lot of patients with severe immunocompromise, actually they don't develop any immunoglobulin. They don't have any immunoglobulin. So that again difficult for you to use the serological markers as evidence of infection. And also the conversion from IgG to IgM to IgG can also take time in patients with immunocompromise. So at the end, you need to rely on the history and also epidemiological investigation, like the context and so on. But again, earlier this year, during the early pandemic, for example, like last year, I was in USM. I work most of the time. I work in oncology ward. Even we've got cases of positive COVID among the oncology patients. What we do is we repeat the PCR. And then we postpone all the medication, all the therapy, chemotherapy, radiotherapy, were actually postponed for these children. Okay, and then we repeat the PCR. For example, I reported a case last year about a patient of mine, a leukemic patient with COVID positive, which totally asymptomatic, very healthy, but the PCR remained positive despite on day 28 of sampling. Okay, but we have no choice. We have to postpone. But if you look at large center, oncology center, for example, in Italy or in UK, that data has been found that in fact the consensus they come out, the oncology society has come out with consensus guideline that actually we can continue treatment despite they are having COVID infection, especially those who are asymptomatic and not that severely immunocompromised. Okay, because at the end, we know the pathology that leads to morbidity and also mortality in COVID-19 is actually the cytokine storm, which most of the time actually absent in those with immunocompromised. If you got poor immunity, right? So how can you develop or you manifest your inflammatory response? So that's the weight. That's the things that you have to weigh lah. Because if you not treat, then they may die from their underlying problems. But if you treat also, it doesn't cause much problem. For example, if you give remdesivir or corticosteroid, which is the immunosuppressed, on top of patients already immunosuppressed, so we're not sure the outcome. But so far the data shows that treating immunosuppressed children with COVID-19 with continue the current treatment of chemotherapy and radiotherapy actually leads to no increase in comorbidity, in morbidity and also mortality. So any other questions? I know at the end we are treating patients.
A little bit about the vaccine.
Okay, huh?
Are we?
Datuk. Yes, Datuk.
A little bit about the vaccine in children. WHO still not advocate vaccine in children. Because of the they still unable to decide in terms of the balance, the risk and benefit. Because in children, the infection usually is mild, and then for them it's no urgency yet, and they need more data. But I think CDC already allowed vaccination in children above 12 years old. And then the two vaccine now there's some data in terms of safety. One is the Pfizer, the second one is the Sinovac. Even Sinovac now they are now start to have trial to 2 years and above already in Sinovac. So well, we see how if vaccination in children, but I think at the end of the day we still have to go, especially when it comes to children. But children in school, because the school is the cohort is very big to just to not to interfere, because it's in children in school. You know, children, how are we going to manage them to follow the SOP? And then, you know, children, when talking about herd immunity, when they are all children in one school, they no more herd immunity when they are grouping together. Herd immunity by Childre is that the spacing of the person in the community is such a way that we can stop the transmission because there are many layers of those being immune. But children in the school, if they're not immunized, and then we have a cohort with a place where there's non-immune person, and then, you know, school, thousands of them in one school can go to 1,000. But then still the question of risk benefit for children in terms of severity of disease and infection.
And then again, studies in children are very difficult to perform. Even in adult studies, trial of vaccination in adult is also difficult. So most of the studies we call bridging studies. So we use surrogate markers rather than the real marker of effectiveness. For example, in COVID-19 trials, what we did, what usually the researchers did is, rather than we measuring the impact of the disease, such as morbidity or mortality or symptoms or severity of illness, we only measure the serological marker. For example, the level of immunoglobulin level, IgG, IgM against COVID, or neutralizing antibodies. So this is just a marker, serological marker. So it may not translated into phenotype or into the presentation, you know. So it's very difficult. These evidence are actually not straightforward. So studies is quite difficult now because there's a lot of ethical.
Do we know what?
Hmm?
Is there any explanation why is it the 30% newborn can be negative PCR?
Pardon?
Is there any explanation why 30% of the newborn negative in PCR yet they infected? Is it because they don't go to, because the technique of PCR we're taking by mucosa and then they don't have mucosal infection, they have systemic infection? Is it that's explanation?
I didn't find that explanation actually because I've searched in the few systematic reviews on this topic looking at vertical transmission. There's no theory or there's no explanation on this. However, because most neonates, okay, they like the doctor mentioned, those who died or get severe infection are those diagnosed as sepsis, so who fulfill the definition of sepsis syndrome. But so possibly they turns out become like viremia rather than respiratory tract like common children. Possible because of the lack of ACE2 receptor, so the virus less likely to bound to the surface receptor on the lining of the respiratory tract or even the lung, but rather they get through because it's vertical transmission. Most of the time there's possible risk of vertical transmission as well. So if this is vertical transmission, so
what
it's
is
directly to the
incident of vertical transmission?
that's a problem. The risk is only from data from available data, it's only 5.7% among neonates.
So
that actually
one in
1 in 20.
5.7% will be in the 10 patient will be two babies, 1 in 2. No, 20%. 1 in 0.1, 0.5.
So 1 in 20. So every 20
1
babies.
in 20, sorry.
So every 20 babies with confirmed COVID-19, okay, every 20 newborns with confirmed COVID-19. Now, with mother.
Confirm mother is
mother. Yes. So confirm mother. Yes.
So side, it seems that we have no choice. Every cases that from mother who are positive, we have to treat. It is a possibility of COVID.
Because the sensitivity of PCR in units is only like 70%.
70% only, not sensitive at all. Not very sensitive lah.
In fact, IgG, IgM also is very difficult to interpret in units. IgM may take some time if the infection occur perinatally or during intrapartum, so they may take up to 1 week to develop IgM, for IgM to be detected. So if we take the serological level, serology IgG, IgM level at birth, so we may there's a high chance of false negative. And IgG definitely from mother lah.
About breastfeeding, how about breastfeeding? How much it help?
Okay, actually breastfeeding, because so far, okay, despite there are few small case reports and also case series found PCR positive viral particle in the breast milk. However, there's no actually evidence from systematic reviews, multiple systematic reviews I've searched, none actually shows that breastfeeding actually can lead to infection in children. But there's few like case reports and small case series found that actually breastfeeding infant that directly breastfed from the mother with COVID-19, even though they're positive, which is even though they are positive, they are less likely to develop severe illness. So we think from the limited evidence, breastfeeding is actually effective and is protective to the baby rather than
beneficial.
It's beneficial. However, because evidence is limited, so you have to weigh you have to weigh. But at the end, breast milk is very important for the child. The benefit is much more than the risk. There's a confirmed benefit rather than hypothetical risk of using breast milk in baby lah. So I think the way forward is actually give breast milk rather than we have to give breast milk to this baby. Okay, I think that's the best approach. Maybe not breastfeeding lah, tapi breast milk we have to give.
Okay, any questions?
And the other thing is, you know, in breast milk, there's presence of IgA, kan? So, and we know IgA is the only immunoglobulin that can actually protect mucosa. So it's very good to protect the child from exogenous infections rather than vertical infection. Vertical infection may not be protected by breast milk, but we know that by giving the breast milk, it will protect the child from acquiring infection through the upper respiratory tract.
Any specific way handling expressive breast milk? To Syed can answer, Syed. Syed, anything you want to comment about the questions?
We have a guideline already, so the guideline is already very clear of how to handle it. If I answer here, it's going to be very long. You can look at our guideline.
I think at the end we have to understand how COVID-19 transmit. Okay, COVID-19 transmit through droplet and also through particles.
Now airborne, it's already droplet lah. It's already
it's droplet. Because it's a virus, it still need a host. Okay,
no, we're talking about airborne. It means just need a few small, very small droplet.
But
it's
still,
not like it's not like TB. You actually large droplet.
Yes.
So
if you got, for example, like if you put a breast milk infected with COVID, exposed to the air, okay, I'm not sure how. I don't think there is for the breast milk to infect others, to transmit the virus from the breast milk in a cup to the child is very high. In fact, it's almost negligible, unless if you do something to the breast milk. For example, like if you suction or nebulize the breast milk, then there's a risk of infection. So handling breast milk will not infect the handler. Okay, unless the handler like sip it or maybe exhale, nebulize the milk, then only it can infect others. So I think handling can be done lah, but definitely precautious.
Should be considered as biohazard.
Actually, the issue with handling of breast milk, we are not that worried about the breast milk. The breast milk never has been an issue. The issue is the thing that the mother touches, because there are suggestions that COVID stays to whatever you touch and everything. So that is the concern lah. So that is, if you look at our guideline, the more we concern are the things that the mother touches, the things that are surrounding the mother, and so on and so forth. So that is what we are trying to protect lah. The idea is we want as much as possible to reduce risk of infection towards our healthcare workers and to reduce risk of horizontal transmission. So that is the main thing that we are trying to prevent. So we know that risk of vertical transmission is very, very low, but we don't want to increase the risk of horizontal transmission. Yeah, that's it.
Okay, I think that's it. Kena join type program pula. Anything tak ada apa kan?
Okay, that's all. So I pass the mic to the chair.
All right, thank you, Alhamdulillah, and thank you so much, Dr. Alwi. So we will end today's CME with Tasbih Kifarah and Surah Al-As. So once again, to all doctors, kindly fill in the Google form that I have pasted the link for CPD points. So I guess that's all. Thank you so much, Dr. Tawi. Assalamualaikum.